Hello and welcome to this Quality Week session on decision-making data. NHS Lanarkshire rapidly established a pan-Lanarkshire COVID-19 assessment pathway during March 2020 as part of the national response to the pandemic. The aim of this was to provide a redirection away from routine GP pathway. It saw the public being asked to call the 111 number, who call handled all people who called there, querying whether they had COVID. Where necessary, they were then sent down to a local triage hub, and if clinically required, were seen by a face-to-face assessment centre. Efforts were incredible and saw the establishment in under 2 weeks of the assessment pathway. From the commencement of the service, data collection and the use of data was underpinned the service development and ongoing delivery. Data is often seen as the difficult part of quality improvement. And while there were challenges around this, and we will share these with you today in the session, it is absolutely important to recognise that data has played a key part in the successful delivery of this pathway across Lanarkshire. I'm now going to pass over to my colleagues, Lynn Stewart, who's the Improvement Manager, and Hazel Tyre, our Senior Information Analyst. Because as the Senior Improvement Manager, whilst I was there at the beginning, thinking about what we could do with the data, it was these two incredible people who actually took us forward on our journey. Thank you.
Thanks for that, Judith. I'm going to talk about applying QI in relation to the community COVID pathway and just briefly mention the key elements. So you have your process focused, saving your time and your money, outcome focused, improving health, improving the journey for the patient, behaviour attitude, which is both patient and staff. Monitoring in QI is essential. You do pre, during, post, where you are, where you want, where you were, where you are, where you want to be, and always, QI takes time to implement. So this is multiple tests, multiple meetings to discuss how you move things forward. We're going to discuss this throughout the presentation. However, I'd just like to, share that all of this was imperative for the community COVID pathway, and the data provided was absolutely fundamental in discussions and the decision making evidenced, and we're going to display that later on, hearing from different people. This also provided reassurance of what was actually happening on the ground. Sometimes you might have an idea of what's going on, but then your data gives you the evidence, which is essential. So recognising the dimensions, some of you may be aware of the different dimensions of quality, and you'll know that they're all linked together. One doesn't necessarily work well on its own, but when they're all together, it delivers a better service and it makes the flow better. And it's your safe, effective, person-centred, equitable, efficient and timely. Avoiding harm wherever you can, establishing partnerships between staff, patient, and just getting things to work at a better rate and work the best that it possibly can. So there's multiple steps in decision making. You need to ask, what's the value of the data? How is the data going to be utilised? In respect to this, how did the data support the delivery of the community COVID pathway? What challenges were there? What learning can we take away, and how can we move forward? And all these are very important questions. So Hazel and I had a conversation with the locality manager of the community assessment pathway in primary care out of ours, Maureen Deary, and here's what she had to say.
Hi Maureen, so we're just going to ask you, between Lynn and myself, a few questions about the community COVID pathway data. So the first question is about the value of the data to yourself.
Okay, thanks Hazel. The COVID daily return for the Hub and Assessment Centre has been absolutely invaluable from the start of this process. It's been crucial in supporting the service in planning and delivery. The daily cumulative report has been so responsive to the service needs. It's been incredibly beneficial. That's a full system report, and that we can see the demand from the initial consultation when our patients are contacting NHS 24.
Excellent, thank you. The next question is about how the data was used, and in particular how it supported the delivery of the pathway.
Okay. The data has been used to inform efficient service delivery. It's identified demand and capacity. It's been really, really helpful in analysing activity levels, especially probably during specific peaks during the 24-hour service. Has let us plan the expected workforce and the minimal workforce that's required to deliver the service. And that's been from call handlers to triage clinicians for face-to-face, domiciliary visits, and the number of support staff that's required to actually deliver the service. And with the support staff, I'm talking about even, the number of, drivers if we're requiring, the X amount of home visits, or whether it's for our patient services for our volunteer drivers. So that's been really, really helpful. The activity levels have been key at key times during the planning of the stage. So it's allowed us to actually stand down the service or increase it. It's also let us look at the number of clinicians that we require on every service. And that's actually been a cost benefit to us as well, which has been really, really helpful because, it's definitely capacity and demand. And what happens with the data, it's demonstrated that at times of the day, it's there's more people phoning in, for example, maybe from about 10 in the morning to about midday. And then we've obviously got time, we've got a number of kind of times that there's a lag between them, so we could manage, the workforce round about that. That's been really, really helpful.
Very good.
Also, what I would say as well, sorry, just is that the graphs and the infographs that we've had, they have been really, really good at informing, the operational, just our meetings, informing our wider stakeholders and the staff, just letting them actually see the amount of activity that's been going on, and they've all really, really enjoyed that.
Which is good because they know that they've been so busy, but to actually see the numbers of calls and patients is good, isn't it? Yeah.
Mm-hmm.
That's great to hear. Thanks very much, Maureen and Hazel. Maureen, what challenges would you say that have maybe been encountered along the way?
Hi, thanks, Lynn. I would say that we've not really noticed many challenges with the data, other than the fact that probably the timing between the data and when the calls come down from NHS 24, when looking at the disposition time, when they're appointed, and sometimes that doesn't marry up because the data has been put in between, the 8 in the morning, to the following morning. So sometimes it's difficult to separate that. Hazel's had a number of workarounds though through that, trying to kind of support us as much as possible and broke it down into different graphs and tables. So on the whole, I would say that, there's not been any challenges that we've encountered.
Fantastic, that's good to hear. What learning would you take from this, and also moving forward, what would your wishes be and what would you change?
Okay, just the learning and the moving forward, I would say it's informing our next steps and the time frame for the service, because obviously this was set up as a temporary service over a year ago, and we're actually kind of obviously looking at that to see, what we do with the service going forward. I would also say the activity levels and the graphs have been, as I said, they've been so powerful to demonstrate the activity. And in the number of interventions that we've used. So that's been really, really helpful in taking it forward for the learning for Scottish Government, from a board papers all the way up to Scottish Governments. So it's utilising it, in papers going forward, planning different services. I think one of the things that we've taken from this, we're actually on the back of the COVID pathways, we're actually working on the back of a lot of out-of-hours processes. And what it's done for us, it's actually demonstrated how powerful the data is to highlight the activity levels for the demand and the capacity. So we're hoping to take a similar process and a similar approach into out of hours to just to monitor the service delivery within that service as well.
That's excellent.
Thanks very much.
Thank you.
And thank you very much for your time.
Okay, you're welcome. Thank you.
Thank you.
So that was Maureen Deary there giving some feedback. So the value of the data. What do we need? What data do we need? So this started off as a cumulative file, because instead of sending 6 figures every day, the cumulative file was created. And, you know, who'll benefit from the data? What do we need to show? Who do we circulate it to? This is all the questions that you ask yourself. There's no point in collecting things that you don't need to collect. So when the community COVID pathway, you know, was set up, it was a case of, right, well, we'll need gold command, silver and bronze. This then grew, and then it was circulated to a few consultants in public health, the quality director, the resilience team. And as time's going on, the teams that are needing involved for their input and how to make things better and how to take things forward grew. And it's a continual improvement, and you don't get it right first time. So you do something that works, and then you take a step back and think, right, how can we make this community assessment, community COVID pathway better? How can we improve the patient's journey for A and B? How can we improve the staff? How can, you know, where do we go for here? So it's continual plan, do, study, act, constant all the time. So there was a Scottish Government return at the beginning, and then there was the 6, that was the 6 figures. Then there was the weekly dashboard, which went to fortnightly, which went to monthly. There was the daily activity file that was then growing and growing. Hazel was getting asked to add in extra things all the time to report back to Gold Command, and which informed their decisions. And then that then became more streamlined and more focused, because there's no point in recording figures for the community COVID pathway that weren't necessary at that time. So, you know, it's always under, we're always revising it, and then you do your monthly infographs so that it's got the data visual, which is much better for people to look at, and it shows the actual activity of the COVID pathway and what's going on, because it has been up and running, and there's been a lot of fantastic work done, and the data is here to evidence that and how it shows you the decisions. So for how we got to where we were to where we're at, I'm going to pass over to Hazel, and she's going to go through how reporting has progressed over the months.
Thanks, Lynn. So the reporting for local purposes started on the 23rd of March 2020, and the image on the left of the slide is a template that had to be returned to Scottish Government by 9:30 every day, starting from the 26th of March. This return needed to show activity for the 24-hour period up to 7:59 that morning, split into in and out of hours time periods. Scottish Government wanted to know the number of patients triaged to the COVID hub by NHS 24 and the number of patients triaged by the hub to the community assessment centres, and they also wanted to know the number of patients sent to hospital by either the hub or the assessment centres. After a week or so, I realised that more information was required than just the daily templates that were returned to Scottish Government, so I created the new spreadsheet, which became the daily reporting tool. This contained cumulative data from 23rd of March 2020 onwards. I continued to show the activity by day, and I also added in other tabs to the spreadsheet to show daily totals and weekly totals. And I also added in some graphs to demonstrate the fluctuations in activity. These graphs were both done daily and weekly. I then decided to add in columns to expand on the number of patients hospitalised by showing the number of patients who attended a Lanarkshire A&E or were admitted to a Lanarkshire hospital, and this was incredibly useful to the service over the last 15 months. Initially, I noted in a column that some patients went directly to a ward and bypassed A&E. I subsequently added in another column to keep track of these numbers, and the numbers have been quite substantial as time's gone by. If we then move on to the next slide. We then decided to add in another couple of figures, so we wanted to record the number of calls to 111, which is the NHS 24 activity, and this enables us to show the difference between the number of calls triaged by our hub and the number triaged by NHS 24, the difference in those two figures shows the number of calls that NHS 24 have closed off. This is either by them sending patients to A&E or sending out an ambulance to the patients or directing the patients to self-care. We also added in the number of COVID home visits, and these are obviously very resource intensive. Another new addition was to look at redirections. These occur when the ARIC cannot be adequately staffed, so patients are redirected to A&E instead of being given an ARIC appointment. This requires manual checking of Adastra and a look at whether the patients were admitted to hospital after attending A&E. In September 2020, a weekly early warning matrix workbook was created, and the SPC charts from here were added to the daily reporting tool in February 2021, and those charts are on the left-hand side of this slide. If we then move on to the next slide. In February 2021, we also added in a new tab to the file, the new front page, which is on the left of the slide there, which included hyperlinks to the different pages within the tab, and the infographic which is used in the ARIC newsletter. A table and a graph, which had been contained in a separate workbook previously, were then included in this file. These had previously been sent out every Wednesday in a separate file, and this showed the number of COVID swabs taken in the assessment centres in ARIC and the number and percentage of these which tested positive for COVID. If we then move on to the next slide. These reports haven't only supported the COVID pathway, they've been required for Gold Command, for the resilience team and the public health team, amongst others, to aid the awareness of the impact of COVID on NHS Lanarkshire. The figures are also used by Strathclyde University for their COVID bed modelling project. The distribution list for the daily reporting tool now stands at 36 people. The public health include the numbers in their daily reports, and the figures have also been used by Clinical Quality for their dashboard. The resilience team use the figures for their CRIP, which is the Common Recognition Information Picture, which is sent out to the command groups within NHS Lanarkshire. The next slide is showing a couple of the ad hoc requests that we've received. In fact, it's showing 3 of them. So areas of interest have been the proportion of patients triaged from the hub to assessment centre or ARIC in hours. This has varied throughout the different peaks and troughs of activity. You'll realise that I'm referring to assessment centres and ARIC, which is because initially they were called community assessment centres, but they're now called ARIC, which is the acute respiratory illness centres. Also of interest in here is the time that patients initially call NHS 24. The peak time has been 9 AM in the morning, with another peak at 6 PM, which happens to be when GP practices close, people traditionally returning home from work. If we move on to the next slide. The proportion of patients sent to hospital by the assessment centres has varied over time, and this particular ad hoc looks at the number and proportion of patients sent to hospital by age group, and it's interesting to see the variation throughout the age groups. This ad hoc was for the first 7 months of the pandemic. If we then move on to the next slide. So this looks at the challenges of reporting, and for DASH reports, people often think that figures appear at the touch of a button, and as we all know, they really don't. So the Adastra reports require a lot of manual manipulation to obtain the figures required. This is really because of the way the case types work within Adastra. So the reports bring out the final case type, but quite often we want to look at the previous case type. An example of this is prescription requests, where the COVID case type was COVID advice, but the final case type is prescription request. So we actually need to count the COVID advice part of that. Another pressure has been time. So when the Scottish Government wanted their figures by 9:30 in the morning, it took more than 90 minutes to obtain 6 figures, which is quite unbelievable. But we also needed to report on patients who were actually just entering the COVID pathway just before 8 o'clock that morning, and Scottish Government wanted to know the details of these patients and their outcomes by 9:30. So clearly a lot of these patients, we had to update the figures the next day. time. Still, although the reports don't need to be out by 9:30 for Scottish Government, they're still required by other departments. So we just try and get them out as early in the morning as possible. So Lynn and I had a conversation with Associate Medical Director Sharon Russell. So here's what she had to say about the COVID assessment pathway data.
Hi, Hazel. Hugely, I don't know how I could describe the descriptors for it really. I think it was hugely valuable, used it regularly. It was foundational, quite pivotal to the decision making I think that we made and the discussions that we had.
Excellent. How were the data used that was provided?
So it was used on a number of different levels. It was used personally as almost like a reassurance. Even now, when I get it through on a daily basis, you would look and just make sure, even though you felt you got a close eye because you were on the ground of what was happening, I still like to look at the trends personally just to reassure myself that what I was seeing on the ground was giving me feedback to that. We used it in discussions within localities, within the organisation more widely. Used it on national meetings on a weekly basis to support the feedback we were given both to other health boards and to the Scottish Government, and it was very supportive of everything that we did. Yeah.
Thanks for that, Hazel. Shan, how did the data support the delivery of the community COVID pathway?
So pre-COVID, it was one of, I think, our tasks or our jobs that we were going to try and bring in evidence about what we're doing before we do those things. So by making any decision, thinking about it, using the evidence, and data is part of that evidence. And what we did this time is we actually made that a reality, so that on a daily basis, if we were making a decision about something, we would completely go back and say, well, is that what the data is showing us? As well as do it the other way around. When you're looking at the data, say, actually, I noticed this trend. It looked like it was happening 2 weeks ago. Now it's pretty consistent. You can see that that's happening. What can that mean? And then we could take what we'd noticed, both to sort of strategic meetings, let's say for the senior management team. We could also take it nationally and say, has anybody else noticed this trend? Because we've noticed this. And on more than one occasion, when we spoke nationally about the trends we'd noticed because of the quality of our data, other people said, oh yeah, we'd sort of noticed that as well, but they hadn't got the data that we had to show that as evidence. But it gave support to those conversations, which I think was really meaningful. And it was the first time, I think, in my career I've seen that become a reality. The message that you're trying to get through to people to do that actually became a reality about these things.
Fantastic, thank you. And along the way, as expected with the pandemic, challenges. What challenges were encountered?
Challenges around the data itself. Sometimes I wasn't that sure that what I was seeing was a reality, and I would pester Hazel and say, Hazel, this is what I think I'm seeing. Is it true? I'm sure she was very patient with me about it. And occasionally now she sends an email saying, this is what I think the data's saying. So maybe she's preempting the phone call. I don't know. Other times when each of us now spoken to other clinicians, we have our favourite tab or our favourite graph. Some of us have the same favourite graph, and at one point one of my favourite graphs disappeared, and I was sort of panic stricken. When did that graph disappear? So various of us had bits of data that we would like. Some like numbers, some like the run charts, pictures, and that's what we know. So we know that people look at data in different ways, and that was what you heard through the conversations, that people did have their favourite bit of data that helped them move forward, and I think it was really nice that. That was there for us in different ways, so that each those people who work in different ways could be facilitated to access it.
Fantastic, thank you.
Brilliant. What learning would you take from this, and also moving forward, what would your wishes be and what would you change?
So I think hopefully it has absolutely embedded in, not just strategically and at a senior level, the use of evidence and data to inform our decision making and our conversations, but what it's done on a much wider level, hopefully, is to show people that we've been doing that. It's been very visible. So that as we're coming out of COVID and we're going to be looking to renew, recover our other services, we can now hopefully embed this in without too much of people blinking and being sort of questions about it, because they see it now as a normal way of working. My only concern, no, it's not a concern, that's too strong, but it's just to me, data and evidence is one of the things that inform our practice, and we've not to use it at the expense of others. So there's other things within that decision-making process. So I think that's maybe one of the next skills that we have to learn is how we weight these different things that inform a decision making, because it's not always all about the numbers, or it's about how we make how we explore the intricacies of that and the complexities, because as we know, medicine is a very complex system.
Thank you very much, and thank you very much for your time.
I'm delighted to, and thank you for all my data this year.
Thank you.
Thank you.
Thank you, Sharon and Maureen, for sharing your experiences of working alongside us as part of the team, and indeed the value of data. But most importantly, thank you for Hazel and Lynn, who have taken the time today to share all their efforts and experiences of establishing this data set and how it's worked. Our session, I hope, has given you insight to the value of data and how it informs decision making. They do say there's no stories without data, and that is so true. So it would be completely remiss of me at this point not to conclude and acknowledge that there are incredible stories to be told of the CAP journey since March 2020 and everything that has been achieved. And it's been a whole wide team that's achieved that. And there's far too many people to name. But I think what's important, and as shown in this data, is that the incredible journey and the impact that they have made regarding the number of patients that they've either triaged, seen in a hub centre, and indeed then supported them on their journey through their COVID. On a final note, should you wish any more information, please feel free to contact us on the email address below. It's not been possible to share everything today. We just wanted to give you an insight and demonstrate to you that the decision-making data is so powerful and can support incredible things to be achieved. Thank you.